This episode of Inside EMS is brought to you by Lexipol, the experts in policy, training, wellness support, and grants assistance for first responders and government leaders. To learn more, visit lexipol.com. That's LEXIPOL.com.
Well, here it is. The Inside EMS podcast is on the road once again. It is my time to now do EMS work away from the house. Kelly Grayson is in his abode in upstate New York. KG, welcome to another great edition of the Inside EMS podcast. That was just a horrible opening, wasn't it? I mean, there was no form or function to that opening. After 600 shows, you think I'd have this down.
Yeah, we have to consider the guy delivering the opening, par for the course.
Whatever, man.
So
let me see you do an opening. You do an opening. Let me hear you do an opening.
I'll watch Carnival Barkers for a little while to get in the mood, and then I'll do the opening one time.
All right, you'll come
so
back,
where are we
man.
at on the Chris Cebollero World Tour right now?
I am in Charleston, West Virginia, and let me tell you what. From St. Louis, it's like an 8-hour trip. And I should just drive, because driving probably takes me 9 hours. But, man, I got in the airport yesterday. It was 9 o'clock in the morning. I didn't get to Charleston, West Virginia until 5 o'clock in the... I don't even know if this is still the United States, to be honest with you. But
I've been to Charleston. It
looks like a great little city, man. It's very green. It's actually raining today, but it takes forever to get here, man. You got to go to Atlanta. And, of course, I think even when you pass away, before you go to the pearly gates, you'll have to transfer in Atlanta. Everything goes through Atlanta. But it was a long trip, man. I think I could drive here in 9 hours, and it took me 8 hours to get here on the plane. I don't know that it's worth it.
The last time I was in Charleston speaking at an EMS conference, I think I was doing a multi-city trip. So I booked it as several one-way trips and made the mistake of booking my final leg of my return flight home out of Charleston, South Carolina.
Oh, I remember that. I remember
that
when
sucked.
You did that.
That sucked. I had to rent a car and just drive to South Carolina, and God, that sucked. But hey, I'll know better next time. Now I have Nancy make my travel itineraries, because she does so much better at it than I do.
Funny. So Kelly, today, I think over the months we've started to see an increase, and you and I have debated this about more and more challenges that EMS providers are facing. And, we've talked about body armor, and we've talked about arming EMS providers, but we are starting to see more and more attacks and assaults. I mean, there was just reading something yesterday about an ambulance that was shot at by paintball. Well, it's paintball today. It's .357 Magnum tomorrow, right? And I think that it's becoming increasingly dangerous for us to do our job. Well, as we go into the EMS1 files, there was a great article that came out June 3rd, 2024. And we've been on this article kick, because we did an article last week as well by Joshua Davies, as an RN. And he's talking about, gives us his guide to chemical restraints, critical insights on the safe administration of ketamine, Versed, lorazepam, Ativan, and Haldol. And, it got me thinking, as we start to go through our daily routines, I think that chemical restraints are really something that we have to be able to put back into the forefront of everything that we do. Back in the old days, Kelly, before electricity, you and it was Haldol that was on the truck. This was something that was really something that we used, and we had the ability to use. And then it seemed that we moved into chemical restraints. Into 4-point restraints. And then more and more, it looks like we started to get away. And then when we started to have trouble with ketamine and, the challenges that were going on there, we've gotten away from the use of chemical restraints. And I got to tell you, man, I think that it needs to increase more than it needs to decrease, because I worry about, how many times, we used to give Haldol IM. And how many times, I can't count, probably, one time I'm really thinking of, I was on the floor with, on my back with my legs wrapped around the patient's legs and my arms wrapped around their arms, trying to hold them down because this guy was just stronger than me. And my
Yeah.
partner had to give him a shot of Haldol to try to calm him down. And
Yeah.
I remember that clear as day, but that could have been very, very bad for me. But
Yeah.
I don't know that we're taking the need of chemical restraint and using it as well as we could. But Joshua Davies does a great job in his article. I thought maybe this is the time we should probably
Yeah.
talk about chemical restraint.
Yeah, and I think to a certain extent the recent problems with illicit fentanyl and some of the reported overdoses or inappropriate uses of ketamine by EMS providers created a little backlash, and physicians and medical directors are less or more reluctant to grant the use of those medications. And I think that's a shame because fentanyl is a wonderful analgesic agent. It's perfect for EMS when used appropriately. And the same for ketamine. Ketamine's a wonderful dissociative anesthetic and sedative when you use it correctly. But what I see in practice around here is that it takes an arm and a leg and a note from your mother and a virgin sacrifice to get orders for some of these sedatives. And the sad thing is, Chris, is when you really need those sedatives, like you had with your patient, this is not the time to pick up the phone and say, "Mother, may I?" while you're getting your ass whipped. Not only do we need to have these sedatives available to us and appropriate training to use them correctly, but it needs to be understanding orders and protocols so that we don't have to interrupt what we're doing or risk ourselves or our partners to call for orders for that. But it is incumbent upon us to make sure that we actually know the medications we're administering and know how to give them safely. So I agree with you. I think that we need more, not less, but we need to make sure the lowest common denominator, dumbest person in our service can still use them safely.
I don't. You keep saying that dumbest in our service. Let's say the least experienced. Let's not say dumbest. But
Okay, like
I
you've
want to
never
be
run
politically.
across somebody dumb in EMS.
I want to be politically correct here. But you brought up something that I don't want to gloss over because I think it's very, very important. And one of the things, I think about from a leadership standpoint. But before I became an operational leader, I cut my teeth in the clinical side of the business, right? So I was an FTO, I became clinical coordinator, clinical director for high performance EMS system. And one of the things that I took pride on was clinical education of making the paramedics as smart as they can be, right?
Yeah.
So when you talk about protocol versus standing order, we really have to be able to give our medical director the confidence that whatever is in the protocol and whatever he wants to give us in the protocol, we have the competency to do that work and do that skill. And I think that that's the failure of EMS, is that we have protocol. Maybe we'll do a protocol exam, maybe we'll do protocol overview, but really I think we need to be able to have skills competencies and sign the competency off, whether it's during NEOP or whether it's during annual training. So the medical director knows that when I have to reach for ketamine or when I have to reach for Versed, when I have to reach for Haldol, I'm going to know the proper dose. I'm going to know the route. I'm going to know all the things that I need to know because I've been signed off. And then he's given the blessing to say, this is a standing order. So we shouldn't have to do the Mother May I. Anytime we have to do the Mother May I, I've always equated that to the medical director's lack of trust in the providers.
It usually is. It usually is. And I hate to say this about my profession, but it's usually because people have set low expectations for EMS and EMS providers, and they have met those expectations. I run into people all the time up here, back home, that go, how do I get so-and-so to trust us? And how do we get better protocols at my service and so on and so forth? And the first step is always be worthy of them. When people say my medical director would never do that, would never allow that, it's almost always a case of my medical director doesn't think we can, and we have done absolutely nothing to demonstrate otherwise. But once you start, demonstrating that you're taking your clinical care seriously, you're conversant in the science of it, that usually garners you a little better trust. I wrote protocols for half a dozen ambulance services in North Louisiana, and it started with me rewriting the protocols for our service when we realized that they were woefully behind the times. And I went into it with, let me do everything as a young, aggressive, slightly over aggressive paramedic that I think I should be able to do without a physician calling me for orders. And got very little pushback from my medical director, but we got pushback from other people, other services or other physicians, receiving physicians. We're like, who said you could do that? Took about 6 months before they started saying, why didn't you do that? When we proved that we could do it well and that we did it appropriately. And I think the same thing holds true for standing order sedatives and analgesics and that sort of thing. At Acadian Ambulance, I wasn't questioned for giving analgesics, for example. I was questioned for not giving analgesics. And I think that's the way it ought to be. Why didn't you treat this patient's pain? Not whether, why did you give this patient this medication? And the times that I've used sedatives as adjuncts to analgesia, the only time I've ever run into problems was when I chose the wrong one. It wasn't the wrong one. I chose a different one than the protocol specified and didn't document it thoroughly enough to explain my reasoning. But that was the only thing. And
Yeah.
I'll say again, you don't need to give sedatives like ketamine to make the law enforcement's job easier. On the other hand, you shouldn't have to say mother may I when it's time to give one. And when someone is kicking your butt, it's not the time to pick up the phone. We said earlier in the pre-talk about the show that if you only have one tool in your toolbox, so if all you have in your toolbox is a hammer, every single problem gets treated like a nail. And there are some sedatives that are appropriate and some that are inappropriate for a given situation. But if you have them all available to you, then you have a much greater chance of choosing the right one.
Agreed. Yeah. And I think that
in so many places, physical restraint is the hammer in their toolbox, and that's all they have. And
right.
I firmly believe if you have to physically restrain someone, you need to chemically restrain them as well.
I agree. And, a lot of times, police will get into the habit of handcuffing someone to the stretcher, and then they leave you in the back. One of the things that we had put into place in our systems were if you handcuff somebody to our stretcher, you've got to be in the ambulance. You've got to be in the back of the ambulance with that person. So let's go ahead and look at this article, Kelly, because I think it was a nice refresher, right? So a couple of clinical pearls that Josh puts into this article, and I don't know if he goes by Josh. Let's just call him Joshua just in case. I enjoyed the article read, and he puts in a couple clinical pearls of pharmacological restraints. Advanced airway equipment and cardiac monitoring must be available if a patient is going to be given chemical restraints. Number two, if a patient's respiratory status declines, he has ALS providers must be willing to take over the airway to prevent hypoxia, which I agree with as well. And I have had those declines when I have given Haldol, where people's respiratory depression has become very prominent, and I've had to bag them on the way to the hospital. I didn't have to worry about intubation. But so he starts off by talking about a couple of drugs, and the first is Versed. Kelly, I want to get your opinion about this, because I don't know that Versed is a drug to be used as chemical restraint, because Versed is used as a conscious sedation. And I think people that forget the word conscious, right? So if we're going to give Versed, that doesn't mean we're going to knock them out. It means that they are conscious, but they're not aware of what's going on. So I watched one time a physician in an ER fix a dislocation with Versed, and this woman screamed in pain and said, "Oh my God, this hurts so bad, don't stop doing that. Oh my God, what are you doing to me? Blah, 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 blah." And then 25 minutes later, she was like, "When are you guys going to fix my arm?" Right?
Yeah.
She was conscious, she was screaming, but she didn't know that we had done what we did, or the doctor did what he did. So in your opinion, when we think about Versed, is Versed, it's a potent benzodiazepine, right? So we know that it has those qualities, but do you use Versed as a chemical restraint?
I wouldn't use it as a chemical restraint. I would use it just as you said for conscious sedation and anxiolytic. If I'm say pacing someone, or if I have to do a brief but painful procedure that's only going to last a few seconds or a minute or two, that's what Versed's for in my mind. In my experience, if you use enough Versed or Ativan, another one he lists, lorazepam, if you use enough of a benzo to really snow someone, that dose is also an adequate dose to affect their hemodynamics and respiratory drive. And I don't much care for that. I think there are better drugs for chemical restraint than a benzo. It's a great anxiolytic and a great amnestic agent. First time I ever saw that given was on an offshore flight for a guy with a broken pelvis and femur,
Wow.
and the nurse leaned over him and pulled a radio out of her holster, and it bashed the guy right between the eyes and cut him. It was a pretty bad lick.
She hit
And
him
he
on
said,
purpose, or was it an
"Oh
accident?
God." No, she weighed about 90 pounds, and 10 of that was radio. And she bent over the bed, and when the antenna of the radio caught in the bed rail, and just pulled it out of his holster and flipped it and hit him right between the eyes.
Oh, I
And he
see.
said, "Oh God." And she said, "Oh my God, I'm so sorry." And he said, "Sorry about what?" And I said, "Oh, that's a good drug. Great for that sort of thing, but really snowing somebody, I would prefer to use something else."
Yeah. So next one on the list, he talks about Ativan, lorazepam, and it's another
Yeah.
benzodiazepine similar to the mechanism of midazolam. It doesn't have a longer acting. I've used Ativan as a conscious sedation that we had in our system. I've also used Ativan for pediatric seizure, rectal administration of pediatric seizure, which works really, really well for kids. But again, when we think about this from a chemical restraint, do you use Ativan? I mean, is Ativan a drug that
No,
we want to be able to
no,
use?
I lump them all in. To me, the difference between the commonly used benzos, Versed, Valium, and Ativan is duration of effects, and that's about it. They all do the same thing. They all work similar way. It's just how long those effects last. The problem is the effects we want are often, when we get those, it comes hand in hand with the effects we don't want, like respiratory depression and a little hypotension. I would rather not use any benzo, if I had something better.
Yeah. And that brings us to I think the queen of chemical restraint, and that's Haldol. I got to tell you, Haldol works well. It works very, very quickly. As I mentioned, in that situation where I was on the floor, hunkered down, holding this guy down for my dear life, that Haldol worked in probably 2 or 3 minutes IM, which allowed me
Yeah.
to at least roll out from under. And then I think we started to into different drugs. We started to get into some other, but Haldol I really enjoyed. I thought it was a good
I bet you did.
medication, but I think it worked very, very quickly. And I think that when we're dealing with people that are aggressive, we need something that's going to work fast.
Yeah, yeah. You need something that is rapid onset via IM route, because it's not something, or intranasal. Haldol is great. It does have the problem of dystonic reactions, fairly common,
It
which
does,
is
yeah.
why it's commonly given in a B50. They cut it with 5 of Haldol, 50 of Benadryl, and 2 of Ativan. Give it in a cocktail. That's the old tried and true antipsychotic chemical restraint cocktail, and works fairly well. But the reason they cut it with the Benadryl has its own sedative properties, as he points out later in the column, but it blunts the chance of dystonic reaction with Haldol. But the killer with Haldol, and I don't know how common this is, but it has happened, is if you give it to someone in long QT syndrome, it can prolong the QT interval long enough to put them into ventricular arrhythmias like VFib. Droperidol was got a black box warning from the FDA for that very reason, even though Haldol has exactly the same problem. Apparently, Haldol had a better PR rep than the makers of Droperidol had, because Haldol didn't get the same black box warning that Droperidol did. But the risk for patients currently with prolonged QT interval is still there. But I think with that caveat, that's also a pretty good chemical restraint drug. One that I wonder what it would, because I've seen their effects in the hospital. I just don't know what the right offhand the onset of action is the atypical antipsychotics like Geodon and Zyprexa. I have seen those used in the emergency department, and they're great at getting a patient more pliable and pulling them off the ceiling. But I don't know of any ambulance services or EMS systems that are carrying those and using them in the field. But be interesting to explore.
You talked about Benadryl. He does have that in the article, diphenhydramine, and this really is a histamine 1 blocker. And I think to your point of, using it for long acting, I don't know that this is a short acting drug. I don't know if this is something that we use, but I think as for a synergistic effect, I think that Benadryl does have some good properties. But then that brings us to the king, I think, of chemical restraints, and that is ketamine. And of course, EMS now has a black eye because of the challenges that ketamine has had in some of the service areas. And those are documented cases that people can go and check out. And we've even have politicians now that are coming out against the use of ketamine in the field, which anytime that we have politicians dictating clinical practice,
they're going to screw it up. Yeah.
Yeah. And that takes us backward. But what do you think about ketamine? Would you use it?
I think ketamine is a wonderful drug. And to steal a line from one of my favorite physicians, Jason Kodat, ketamine's great. I love ketamine. Sometimes I even give my patients ketamine. He calls himself Ketamine Kodak, but it is a great anesthetic, dissociative anesthetic, and sedative agent used in the appropriate situations with the appropriate doses. And that's the caveat with any medication we give. In the cases that, where patients were sedated and died with ketamine, they both use an inappropriately high dose for the patient's weight because they just, everybody's suddenly 100 kilos for the mathematically impaired. And they gave it to someone who had a report of combativeness, but wasn't currently fighting in combative, and makes you wonder whether they ever actually were or not. But for a violent, physically combative patient, it's a good drug to use. It doesn't affect their hemodynamics as much as the others do. If you have to sedate some for a procedure, like say intubation, ketamine is also a pretty potent bronchodilator. So if you have to sedate the crashing asthmatic kid, for example, ketamine's wonderful for that. It does exactly what you want it to do. Plus, it also dilates the bronchioles somewhat. I think if we use ketamine in the appropriate context and with the appropriate dose, that's a vital drug to carry in anyone's formulary.
Yeah, and I think that one of the things too that ketamine has been doing, and certainly this is something that's near and dear to our heart, is there have been clinics that have popped up that are helping people with PTSD, the folks that are coming back from the war, people that just need to rewire their brain structure. They're getting low doses of IV ketamine, and it seems to be doing wonders. And when we think about the providers that are turning to alcohol and turning to drugs, if this is something that could help them, I think that it's a win-win for everyone. But Kelly, I think that this was a good little show, and I'll just get your closing thoughts when it comes to chemical restraints. But I think they need to be more front and center than being pulled back. I think we need to stop worrying about what we're seeing in the news and train our providers to have the best confidence, the best knowledge, the best skill and ability to give these drugs, and any drug. This isn't just talking about chemical restraint. When we start to use for pain management, when we start to use for seizures, I mean, we've got to be able to be on top of our game when it comes to dosing, clinical dosing of medications, from oxygen to ketamine. And I think that that's where we've started to fail our patients.
Yeah, I agree as well. I think that you should have a fairly extensive formulary of antipsychotic and sedative agents available to you. You may never use them. They may go, and I hope you never have to. They may expire in your drug box, but the cost of having them is far less than the cost of not having them. And that's what we think. We'd like to hear what you think. What kind of sedatives do you carry in your EMS system? What are your protocols like for allowing you to use those sedatives? We'd love to hear your thoughts at the show at ems1.com. Don't forget to rate us on iTunes. And for myself and co-host Chris Cebollero, who really needs some ketamine, Thanks for tuning in to Inside EMS. We're going to catch you guys next week.